Welcome, everyone. This is the workshop on advancing health equity skills for healthcare professionals. Today's workshop is brought to you by No Diabetes by Heart, a joint initiative of the American Heart Association and the American Diabetes Association. We will focus today on discussing how social determinants of health are related to diabetes and cardiovascular disease, some of the potential mechanisms that link social determinants of health with some of the changes that we see in these diseases. And most importantly, we want to walk you through some strategies that you can implement in your clinical activities. Please note that there will not be any CEUs offered for this workshop. However, it's wonderful that you are joining us today to learn more about this important topic. I think I have the pleasure of knowing many of you in the audience, but for those of you who do not know me, I'm Dr. Enrique Caballero. I am an endocrinologist, investigator, and educator. I am currently faculty director of international innovation programs in the Office for External Education at Harvard Medical School, and also director of diabetes education in the postgraduate medical education department at Harvard. I also have the pleasure of being the director of Latino diabetes health at the Brigham and Women's Hospital. I've also had the fortune of working very closely with the American Diabetes Association over the years, and I recently had also the honor of chairing the Healthcare Disparities Committee for the ADA. A lot of interesting work that is being done also by the ADA in this important initiative in advancing health equity. So thanks again for joining us today. Before we begin, we would also like to recognize the No Diabetes by Heart founding sponsor, Novo Nordisk, along with the national sponsor, Bayer. Thank you both for this important support. Today's workshop will be recorded. This recording will be available for viewing on the No Diabetes by Heart website. Notice it's nodiabetesbyheart.org. Please go and visit this website. You can download different materials and access guideline information, case studies, and a full library of earlier webinars and podcasts. You'll find wonderful information that can complement a lot of what is going to be discussed today. So join us if possible. Now, you can see the disclosures also from the speakers for the presentations today. And I do want to start with the program since we do have a wonderful agenda, and I would like you to have ample time to listen to the presentations. And then I will invite you to participate in a particular session, a breakout session that I would love to have everybody participate in it. I'll give you more information later. But at this point, let me introduce the first speaker, and then I'll come back to introduce our second speaker later. Our first speaker is Dr. Ruben Dhaliwal. She is an adult endocrinologist and a physician scientist with a public health background. She is currently a consultant at the Massachusetts General Hospital in Boston. She was the director of the Metabolic Bone Disease Center at the State University of New York Upstate Medical University, where she held appointments in the Division of Endocrinology, Diabetes, and Metabolism, as well as the Department of Public Health and Preventive Medicine. She is the immediate past president of the Great Lakes Society of Diabetes and Endocrinology, and she's a member of the Endocrine Society Advocacy and Public Outreach Core Committee and chair the Society's policy initiative on advancing health equity in endocrine research, treatment, and care. At this point, I want to turn it over to Dr. Dhaliwal for the first presentation of this program. Ruben, thank you very much for being with us. The floor is yours.
Thank you, Dr. Caballero. Thank you very much for this kind invitation. And thank you to American Diabetes Association and the American Heart Association sponsors for organizing this program. I'm thrilled to be discussing this topic with you today. And my goal here would be to discuss some frameworks that are available for us to address these social determinants of health, but more importantly, some practical strategies, how we can address them in day-to-day practice, how we can empower our patients, how we can empower our colleagues, and how we can eventually, the goal being to transform our healthcare system. So this is the definition of social determinants of health. World Health Organization describes this as the conditions in which people are born, grow, work, live, and age. These are the circumstances shaped by the distribution of money, power, and resources at global, national, and local levels. So these social determinants of health are mostly responsible for health equities, the unfair and unavoidable differences in health status seen within and between countries. So essentially, this definition is telling us that the key determinants of health lie outside the healthcare system. Now let's look at the definitions for health disparity and health equity. So health disparity is defined as a particular type of health difference that is closely linked with social, economic, and or environmental disadvantage. The key word here is systematically experienced greater obstacles. So that's what is leading to these differences in health. Health equity. So I have two definitions here on the right side. First definition is from the US Department of Health and Human Services. And this definition is attainment of the highest level of health for all people. And then it goes on a discussion about what it is required to achieve that health equity. And then the second definition here is from World Health Organization, which talks about absence of unfair, avoidable, or remediable differences among groups of people. And again, defining the basis being the social, economical, demographical, geographical, or other dimensions of inequality, such as sex, gender, ethnicity, disability, or sexual orientation. So we do understand that health inequities are unnecessary, are avoidable, and unjust. With that in mind, what has been proposed as framework to address these social determinants of health are in this figure. So we do see there are 5 different frameworks proposed here. Each of these frameworks presents a complex interaction between social determinants of health, and there is a significant overlap at times in these specific factors among these frameworks, although these determinants are grouped differently in an individual framework. So let's look at the World Health Organization here. So the first category here is socioeconomic and political context. This is a macro category, which comprises of policies regarding labor, housing, and public policies. In the same category, they include cultural values, our society's views for race. So that's just to emphasize what this one particular social determinant of health category looks like. But as you may notice, there's quite a bit of overlap I mentioned. What is common and at the forefront in these frameworks are the socioeconomic determinants. And there is an intersection between one's education, employment, income, where they live, what they eat, which will eventually determine how will their health be. And that is what is being conveyed here. What is even more critical is that these social determinants of health are cyclical and intergenerational in nature. And this is true for anyone in any sector. This is what sets up one for being disadvantaged. So certain individuals or subsets of population are disadvantaged because the conditions are disadvantaging. And you can see depicted in this figure is a vicious cycle that will eventually lead to vulnerabilities across the board. And that's just showing you here the socioeconomic factors. There are no clinical variables included on this slide. So an individual's educational attainment, which is a quantitative measure, And then educational quality will determine the employment status. That will in turn determine the household income and their poverty status. And that will then determine how much they can afford, their neighborhood and physical environment factors. So this is something key, that there is no clinical variable yet on this slide. So that remains to be yet discussed. With that, I'll take this opportunity to ask audience some question, and please type your answers in the chat. We understand all these factors depicted on this slide are modifiable factors. We also understand the clinical care and treatment variables that we work with and we address are modifiable to a greater degree. So my question is, what percentage of these modifiable contributors to health outcomes are related to clinical care and treatment? I'm just going to pause here for a few seconds and see what numbers are popping up. Yes, somebody asked to repeat the question. So my question is, what percentage of modifiable contributors to health outcomes are related to clinical care and treatment? Okay, so I have a wide range of numbers, percentages showing up in the chat. Okay, great. So this is a remarkable fact that only 10 to 20% of the modifiable contributors to health outcomes are accounted for by clinical care and treatment. The 80 to 90% of the modifiable contributors lie in the social determinants of health. So for example, how have we learned this and come to this conclusion? So the prevalence of cardiovascular disease in African Americans with diabetes is lower than in whites. But we do know that the cardiovascular disease mortality risk is similar among Blacks and whites. We also know that Blacks have 1.9, so almost double, the risk of all-cause mortality from diabetes when compared to the all-cause mortality in whites with diabetes. So this brings us to two different questions. One, if the prevalence of cardiovascular disease is lower in Blacks, then there must be differences in incidence and mortality. But why are there differences in incidence and the mortality that we are seeing? And also, it raises the question that there may be non-cardiovascular disease related factors that may be contributing to this mortality, even the all-cause mortality seen in this population. We also now have data that Black patients are less likely to have an NO-A1C measurement or be prescribed SGLT2 inhibitors and GLP-1 agonists. So what the conclusion here is, if we are to continue the advancement in the management of cardiovascular risk factors, we must concurrently address social determinants of health to ensure that we achieve those outcomes. And just to highlight, social determinants of health are not a recent addition to our knowledge. What has changed over time is the imperative that drives the change in social determinants of health. And these imperatives are now in place. So at what levels do we intervene? So the interventions have to be integrative, they have to be synthetic, they have to be at multiple levels. And what is shown in this slide on the left side are individual level interventions. And on the right, these are more structural level solutions. So For healthcare systems intervention, this would include delivery in both clinical care and non-clinical settings, such as outreach to communities and partnership with communities. With regards to healthcare financing reform, these are the payment reforms that support and incentivize specific care transformations that advance health equity. And this is the reason why today there is a focus on infusing health equity principles into our clinical workflows through the use of digital tools. So in all these levels here, what is the common denominator? And that common denominator here is healthcare professionals. So it's you, me, us. Now, for a system to be equitable, the efforts have to be very deliberate in nature, and they have to be applied across the domains of that system. So here, across the domains of healthcare. So we do need systematic efforts, including policies, practices, procedures, integrated throughout our clinical care, throughout education, throughout workforce and research. Workforce and research are pillars of our healthcare system. And I'm just going to briefly touch upon, because we are primarily going to discuss the clinical care solutions today. So workforce, we really have to more effectively enhance representation in our workforce, so that representation matches the demographics that we serve. With regards to research, research informs evidence-based medicine. The lack of diversity in clinical trials is an emergent topic. So if we want to improve interpretation and increase generalizability of findings to our broader populations, we must diversify clinical trial participation and also diversify the research workforce. So for those who are interested, this is an excellent publication which provides a roadmap for leveraging implementation science. What it shows here are these 4 steps, offers these 4 steps to improve conceptualization and include social and structural determinants of health in implementation science. So the steps here are select and adapt evidence, identify barriers and facilitators to implementation, then go on with implementation strategies, and then evaluate this implementation success. And as you may note, that these steps are bidirectional. And that's how it is meant to serve in a closed loop way to continuously refine the processes. Now, coming to our clinical care settings. How do we address these unmet social needs or the social determinants of health in clinical care? The basic steps of identification are similar as in research. And then also you choose a health outcome and define your target population, and then you address the barriers and facilitators. But how do we approach this? So the National Academies of Sciences, Engineering, and Medicine proposed these 5 A's. And the purpose here is to facilitate this integration of social care into the delivery of healthcare. So the first one here being awareness, which is identification of social risk for specific patient populations. Second being adjustment, language literacy concordant services we may be able to offer. We may promote patient engagement, offer open access scheduling, telehealth services, assistance, health-related social needs. We would be screening our patients for all these social determinants of health. Alignment, to engage with other stakeholders in the community and then align the capacity of the community to serve those needs. And then advocacy, which is key regardless of which sector of healthcare, which domain of healthcare sector you are in. And many of us work in more than one domain. So I'd like to give an example here. So let's take an example of a patient who has missed his clinical appointments. And awareness in that particular example is motivational interviewing and asking the patient about reasons why the patient missed the appointment. And yes, I'm able to identify eventually, say, for example, transportation is an issue. What does adjustment look like there? Does anyone want to take a guess in the chat? For a patient who has transportation issue, what does adjustment look like? Okay, somebody wrote telehealth. Wonderful. Yes. So the adjustment, actually, why I want to highlight adjustment, the adjustment is going to be at my end. I want to review the patient's social need and the barriers and assess whether patient needs to be there physically at each appointment. And one of the potential options is offering more telehealth appointments. What does assistance look like in that scenario? In that scenario, assistant could mean potentially offering transportation vouchers, and these vouchers could be to travel to healthcare appointments by using ride-sharing services or by using public transportation. What does alignment look like in that scenario? It looks like it would be investing in the community by expanding those ride-sharing services or time bank programs. And then advocacy, so that eventually, fundamentally, so the transportation system infrastructure itself is changed within that community. So how are the social determinants of health traditionally or typically addressed? They're addressed through population health management. And the reason behind that is because inertia and resources are the two main barriers to getting started. And at the population level, through policies and reforms, we address both inertia and resources. And policies and reforms allow for mechanisms to be in place for integration of medical and social care. So community health needs assessment. We are familiar with the tax-exempt institutions now being required. It's mandatory for them to report every 3 years their community health needs assessment. So that is possible only through policy. So policy allows for organizational level interventions. What we are seeing today is electronic medical records. So this is our clinical decision support tool. So data visualization dashboards. We are using EMR to screen for social determinants of health as part of the rooming process. We take it a step forward and make EMR more actionable, where we can use EMR to incorporate order sets to place closed loop referrals and make appointments. We may offer telehealth. So that's all use of technology to at the population level, how we are going to. At the community level, it becomes even more resource demanding, but those community partnerships are very important. And one of the more common example is faith-based organizations or community center partnerships with grocery stores to overcome food deserts. So these are more organizational and structural solutions. So what would an intervention at an individual level look like? For those of us who are in smaller clinical settings or practices, all of this through EMR that I mentioned is applicable. We can start small. We can start identifying the social determinant of health, the social unmet needs, by surveying our patients, by reviewing our EMR dashboards, or by even starting a small quality improvement project or a learning project. And the goal eventually here would be to, over time, look into our performance data, audit, and refine our processes to continuously address social needs of our patients. These are specific focus areas for healthcare professionals. So they're categorized under 3 categories. First being team-based coordinated care. And here it is about alignment of diabetes and cardiovascular disease management with chronic care model, and then person-centered team care approach, interdisciplinary communication, and then the decision support tools that I just mentioned to meet those patients' needs. When we look at the second category, the guideline-directed therapy, this allows us to address some clinical needs primarily, but also does give us a little bit flexibility to have more individualized approach. But primarily, if you look at the first two categories here, these are helping us standardize the care we provide with some specific individual level approaches. And it is only when we get to this third category, the under-resourced population support, is when we really are looking at individual level care. And the reason here for individual level care is because there are so many barriers for these particular population subsets. And these barriers are in the context of healthcare. These barriers are in the context of their physical environment or their societal environment. So in the healthcare context, these barriers may look like language barriers, communication barriers, health literacy barriers. It could be digital literacy or just low trust in the medical system. And that will all feed into the access to care, that will all feed into quality of care, self-care, self-management, and a patient's willingness to participate in decision-making in that patient-physician partnership. These structural and institutional barriers in the physical context, they may mean not having affordable housing, having poor access to healthy food, neighborhood stability may be an issue, walkability may be an issue in the neighborhoods. In terms of the environmental and the societal context, this may be more about poverty, about crowded multi-generational living, safety issues, or social cohesion. But these are all barriers, and these barriers are contextual in nature. None of these barriers are actually the ones that we are targeting when we are treating our patients in clinics. These are the factors that precede those behaviors that we target in our clinical care. When we are considering factors like alcohol, tobacco use, exercise, diet, adherence, none of that is a barrier. The barriers are in the context of the environment. So it's epigenetics. And we know there's multiple factors that can affect disease susceptibility. They're not just biological, social, and environmental factors and psychosocial factors.
Ruben,
and we will hear some great examples from Dr. Powell Wiley.
Yes, sorry for interrupting. Can you wrap up? Are you done?
Yes, last slide, yes.
Great.
Yes.
Thank you.
So here, this is, so in speaking about those three categories, what we are doing when we are approaching team-based coordinated care or guideline-directed care by goal setting or by delegating responsibilities, including our staff, we are empowering our patients, we're empowering our staff. By offering patients treatment choices available to all, we are giving them equal opportunity for care. And it is, again, only in the third category here when it's going to become even more important, where community resources and partnerships are going to play a role. And the reason for that is because these are the most deprived and the disadvantaged, but these are also the patients who will require the most attention. And there are a number of resources that are available to you. And this is, one of the resources I would like really you to know is 211. And there's a website, www.call211.org. So we can either call 211 or we can go online. And this is a very, very helpful resource if you're in private practice. you can reach community-based organization in your areas, and they can provide information on food banks, shelters, childcare, transportation. And there are a number of other resources, Prepare Project, the Everyone Project, and Health Leads. So really speaking, it is going to be this third category of patients who are going to be requiring the most strategic and most patient engagement. And with that, I am going to wrap up. And I'm really looking forward to my esteemed colleague, Dr. Powell Wiley's presentation. Thank you.
Yes, thank you, Ruben. That was great. It was a great way to putting out the framework about social determinants of health and how important they are for diabetes care. So let's move on to the second presentation. So I want to welcome Dr. Tiffany Powell Wiley. She is an Earl Statman tenure track investigator with a joint appointment in the cardiovascular branch of the Division of Intramural Research and the National Heart, Lung, and Blood Institute and the Intramural Research Program of the National Institute of Minority Health and Health Disparities. Her research program focuses on the social determinants of health as they relate to obesity and cardiovascular disease. Her work was recognized with the 2021 Population Research Prize for from the American Heart Association. She's an adult cardiologist with a master's in public health and epidemiology, and she has served as the first chief fellow in the cardiology division at the University of Texas Southwestern Medical Center. She will expand on this connection between social determinants in obesity, diabetes, cardiovascular disease, and something that I found fascinating, the connection of biology with social determinants of health, some of the potential mechanisms, which I am sure you will enjoy as well. Tiffany, it's wonderful to have you. Thank you very much for being with us, and please take it away.
Thank you so much, Dr. Caballeros, and thank you to the organizers for the opportunity to be here today. As was mentioned, I'll talk a little bit about a health equity focused framework for social determinants of health, but I'll really dig into some of the data that we have about how social determinants of health relate to the development of diabetes and cardiovascular disease, and specifically some of the biologic mechanisms we know that connect social determinants to cardiometabolic outcomes. So I'll start with a clinical scenario. We have a patient, Mrs. B, who's a 48-year-old African-American woman. She presents to your clinic for medical management of hypertension and multiple cardiovascular disease risk factors. She's had chest pain previously, but has no evidence of ischemia on nuclear imaging. Her risk factors include obesity. Her current body mass index is 32.5. And she's had diagnosed type 2 diabetes for 2 years with A1C of 7.5%. Her other cardiovascular risk factors include hyperlipidemia, a history of gestational diabetes, as well as preterm birth. She lives in Washington, D.C., and if you're familiar with Washington, D.C., Ward 7 of D.C., where she has limited access to grocery stores with fresh fruits and vegetables. And her particular neighborhood is surrounded by corner stores with unhealthy food options. And she's also describes being uncomfortable doing physical activity outdoors due to increasing crime in her neighborhood. She uses public transportation primarily, and her healthcare is through a clinic in Ward 7 called the Unity Healthcare Clinic. And so to start off, we'll do a poll question. Which adverse social determinants of health does Mrs. B deal with? Limited transportation, under-resourced food environment, neighborhood crime, or all of the above? Not surprisingly, most folks said all of the above. I hope everyone can see the results. But as I said, not surprisingly, all of the above are really applicable to the what Mrs. B is dealing with as far as addressing her diabetes, but also her cardiovascular disease risk. And so I want to start, just as I said, giving some data that we have. And we know based on data from the CDC and work that was done at the National Cancer Institute, that there's a clear association between obesity and diabetes and premature mortality in the United States. We know, for instance, that African Americans are at highest risk of premature cardiovascular mortality, meaning cardiovascular death before the age of 65. But those premature cardiovascular mortality rates have been increasing among Native Americans and Alaska Natives, as well as young non-Hispanic white women. And what we also know is this data really put a connection between obesity, diabetes, and social determinants of health, where we saw that counties with the highest rates of obesity and diabetes, but also the lowest levels of education, had the highest premature cardiovascular mortality. And this was applicable across racial and ethnic groups in the United States. So it really highlights that regardless of race, ethnicity, the environmental context in which you live, the resources you have access to really play a significant role in cardiovascular mortality. And so one of the recent papers that my team put out was a review really highlighting this connection between social determinants and the development of cardiovascular disease. And what we wanted to do in the framework we put forward was really to highlight these the lives and the experiences of marginalized populations in this framework. We know, as Dr. DeWalle mentioned, that structural determinants are key, and that was really the basis. In these factors include things like a socio-political and economic context and socioeconomic status. Those are key in affecting more intermediary determinants of health equity, and these include the social and community context in which one lives, the social risk, as well as their lived experience within the community, including everyday discrimination. And all of these factors play a role in social position, which ultimately influence psychosocial and environmental stressors that have biologic consequences and affect cardiovascular and as well as diabetes outcomes. And so I'll highlight data that we have, particularly on how neighborhood environment, whether it be the built environment, the physical environment within the neighborhood, or more social factors within the environment, how they play a role in the development of cardiovascular disease. And I'll also highlight data showing how psychosocial factors, things such as depression and social isolation, have known effects on cardiovascular outcomes. So just starting with neighborhood built environment and social environment, we know that things such as social factors such as neighborhood segregation, socioeconomic disadvantage, as well as perceptions of your environment, whether you perceive your environment to be safe or not, all of those influence the development and incidence of cardiovascular disease, but they also play a role in incident stroke, as well as changes in body mass index and development of obesity. When we think of the built environment, there's a clear connection between the walkability of the community, or how walkable an environment is, and incident diabetes and hypertension as well. We do have data as well on food environment as a marker of the built environment and its relation to particularly obesity, but the longitudinal data that this slide depicts, we don't have as strong longitudinal data on the connections between food environment and obesity and cardiovascular outcomes. When we think of psychosocial factors, as I said, factors such as depression or even more chronic stress, those also have been shown to be associated with incident cardiovascular events and cardiovascular death. And then specific factors such as job strain, adverse childhood experiences, as well as perceived discrimination, specifically play a role in the development of cardiovascular events. And more data is really coming to bear to show a connection between social isolation and incident cardiovascular disease, particularly since the pandemic. And so, as Dr. Cabaneros mentioned, we know that there is clear evidence to show a connection between social determinants and the biology of, and really how social determinants get under the skin. There are direct effects on the hematopoietic system, basically the ability to make and produce blood cells. And there's been direct connections between how the brain reacts to stress and the hematopoietic system. There's a clear effect on the sympathoadrenomedullary and hypothalamic pituitary adrenal axes, as well as effects on glucocorticoid and catecholamine signaling. And all of those play a role in how the immune system responds to stress, but also the development of atherosclerosis, which relates to the immune system. And then these stressors can have indirect effects, not only on inflammation, but of course on health behaviors, and ultimately lead to the development of diabetes and cardiovascular disease. And so when we think of, in particular, diabetes and obesity, we know that these environmental stressors can also have direct effects on adipose tissue, whether it be white adipose or brown adipose tissue, and the development and release of pro-inflammatory cytokines from those tissues, which promote inflammation, insulin resistance, and ultimately metabolic syndrome. And so when we think of the development of interventions that address cardiometabolic diseases, of course, as mentioned earlier, we need to think of multi-level interventions at the policy, community, and individual level. But we also need to think of how do we better understand some of these biologic mechanisms. And so just to give you an example, working with, we've developed an intervention called Step It Up that we're implementing in the Washington, D.C. area. This is a randomized trial looking at improving physical activity, particularly among African-American women, using digital health technology, but also using tailored messaging around neighborhood resources for physical activity. But one big part of what we're doing within this intervention is really looking at how or can we better understand some of the effects of these types of interventions that on these biological pathways related to adversity. So we're looking at how, for instance, the changes in physical activity are affecting some of these changes in immune cells that we know happen with stress. And then finally, I think, as mentioned earlier as well, community engagement is a key part of addressing the effects of cardiometabolic health, and really what we can think of as a syndemic of cardiovascular disease, diabetes, and obesity, and how we can improve and reduce the rates of these diseases through the healthcare system. And so for working with community engagement, we need to work in expanding our clinical team so that not only can staff members address clinical needs, but also social needs of the individuals within the healthcare system. But more importantly, we need partnerships with community-based organizations to get input as new initiatives targeting improved cardiometabolic health develop. And one thing that can also happen is actually investing in social needs resources within the healthcare system, so that those things that may not be readily available in the community, ultimately individuals can get access to through the healthcare system. And then ultimately, what our goal should be for any intervention is that it's available to those populations that are at highest risk, that these interventions are accessible and they're affordable if we are to have a substantive impact on promoting health equity related to cardiovascular disease and as well as diabetes. thank you so much. And we're moving on, I think, to the next part.
Great. Thank you, Tiffany. That was wonderful. That's a great presentation as well. So thank you, Ruben and Tiffany. I think that obviously it's hard in just a few minutes to cover everything that is known about social determinants of health and how important this is for diabetes, cardiovascular disease. But I think that these two presentations have helped us all better understand the framework and some of the strategies that could be tried as we all continue to move forward in this field. So we want to move quickly on the next section, and this is about the breakout sessions. We truly would like everybody to participate. If you decide not to participate, we would understand that, but hopefully you'll stay on and work with us on this. It will be only for a few minutes, and then we'll get back everybody into the room for discussion. All right, Gail, do we have everybody? I want to be sure that we have.
Yes, we are back.
Okay, beautiful. All right. Okay, great. Well, thank you all for joining. I want to be sure that I see Tiffany. Okay, yes. Okay, great. All right, and Ruben, you're there. Okay, great. All right, so again, we only have about 10 minutes, but let's make it as productive as possible. So if you were the reporter, rather, the spokesperson for your group, please raise your virtual hand. I think you can go to the reactions button at the bottom of your screen. And then as I identify you, I will ask you in only 1 minute, no more than that, please, just to share whatever you think was the most important part of the conversation with your group. And then we'll just go along, and I'll ask Tiffany and Ruben to just participate as needed as well. All right. And I'm going to start with Angela because she was in my group. So I know how wonderful that discussion was. So Angela, please go ahead and share what we heard in the group, please.
Yes, definitely. So we had one person talk about how their organization has been trying to be proactive at providing diabetes education in the community. And they've even utilized some interns at a local college to kind of help do some of their teaching. But the largest barrier that they've experienced is transportation. One thing that they tried was allowing children to come to the education so that finding childcare wouldn't be a barrier. But they still are struggling. And so one thought that they had was trying to organize some kind of carpooling, maybe with like company vans, but there's liability issues associated with that. So still working through it. We had myself, I kind of shared a little bit about what my organization has done. We have a population health team of pharmacists who do telemedicine to help do diabetes management and make sure patients are on the cardiorenal and cardiovascular protective medicine. So that has been effective at reaching some patients who maybe can't always make it into clinic visits. And then lastly, we had a couple people from the same organization talking about how they have partnered with telemedicine organizations and also a children's diabetes clinic, and they're really working to provide some community education, both at the group level for their school staff to just raise awareness about diabetes, and also at the individual level directly to parents and students themselves to help them become a little more independent at managing their diabetes.
Great, wonderful summary. Thank you so much, Angela. Yeah, so what we found was obviously a lot of different challenges, different factors, all of them tackled in different ways. In the end, probably we need to do everything, but I think that these were great ideas to share in all that. As I said, Tiffany and Ruben, if you do want to say something, I mean, otherwise we can just go through all the other groups quickly as well. Maddie Reinhardt.
Oh, thank you. Hi, my name is Maddie. I use they, them pronouns. I work at community health center called CMAR in Seattle, Washington. And I spoke briefly about a partnership we have going with a local food bank where we've been able to have them deliver pantry items to stock a food pantry in our clinic. And then we've been able, so my site at the White Center neighborhood has kind of piloted this program where we're doing some food insecurity screenings, and then we were able to establish the pantry. And so other health educators within my organization have kind of grown passionate about this as well. And so we've tried to start expanding the food pantries to other clinics in our organization. Shirley was able to tell us a little bit about a program where pharmacists go to patients' homes to teach them how to maybe use a blood sugar meter or blood pressure monitor, and also do kind of like medication education. And then a barrier there would be patients maybe not being super open or not feeling comfortable initially with that kind of education person coming into their home. So needing to build rapport there. And then Tommy was talking to us about VA home telehealth kind of program where they're able to monitor patients' vital signs remotely. And so the barrier there is he works in West Texas, which is very rural. And so the cell signal or internet might not be as strong as needed to be able to consistently get that information. So a little bit of built environment and, income and all those kind of things impacting all of our work.
Thank you. Thank you, Maddie. Yes, I think the challenge is always all these great ideas, how to implement them and sustain them from the financial perspective, because they're not part of the usual healthcare model. And that's where we're stuck. But I think that demonstrating outcomes, a positive effect in outcomes is always something that would help us in that direction. Tiffany, please go ahead.
I was going to talk just a little bit about what our group talked about, since we didn't pick someone to present. But,
okay, great.
But,
so you're the person.
The thing that struck me with the strategies that people brought up is that they're very multi-level, just as we talked about the need for multi-level interventions. There was an intervention that targeted resources and improving care around acute MI and incorporating social determinants into the care for acute MI, which may seem more patient level, but then there was a solution or a strategy around more of the provider level and training providers, and having medical students actually go into community organizations and work within the community. I believe it was in the Bronx, but maybe, I hope I'm not wrong. And then there was work going on at the policy level at the CDC to promote the use of community health workers and highlighting the data that exists in community health workers improving outcomes related to diabetes, cardiovascular disease, and also cancer. And so I think, as Enrique, as you brought up, there's a need for sustainability, but I also think it's important to make sure we're not recreating the wheel and using interventions that have data behind them.
Absolutely. Thank you, Tiffany. Carrie Ann?
Hi, I'm Carrie Ann Krabel. We also did not assign somebody, so I am going to share out what we talked about on our group, similar to what Dr. Powell Wiley was just talking to, in terms of something that people have done in their facilities is really focused on, the primary care provider and linkage to the community health worker. So we heard a couple of different examples of where this is successfully working well within clinics, but it seems that a lot of our stories within our group of high success of connecting through the equity component has been the focus of making sure that the community health workers are working closely with the primary care providers to really focus on, the whole care team being a part of the process of an individual's care. Another thing that we heard that was successful in that was also the utilization of a home health aide, where that community worker was actually going to the house to help for those individuals who actually couldn't make it into the doctor's office. So, in another example of something that was working well for a facility. We had two common barriers that came up that were across all of the organizations that shared. One of the biggest barrier that individuals are facing is transportation issues. That is coming up for most people, high frequency. And then, where there are options for telehealth, these locations seem to be more in rural areas, so they don't have, the broadband to be able to do the telehealth, appointment. So they're trying to figure out how they work through that moving forward. And then the other biggest issue is around some of the reimbursement pieces for certain areas where they're focusing on nutrition, and how do they work through, making sure that they're being supported from a clinical facility around their healthcare workforce team that's focusing on nutrition. And the last thing was just a general focus on healthcare systems for those that weren't in FQHCs. It's just the barriers that come with the common day-to-day of working through uninsured populations, high premiums, how to get individuals medications that aren't covered by insurance, and make sure that the doctors who are prescribing our care teams know how to work through that. And then the last thing where people are giving examples of stuff that's working well is partnering with individuals within the community who can help with transportation needs, and looking at organizations who may provide comp Lyft rides or Uber rides, those types of things.
Great. Beautiful. Thank you. Thank you. Lots of wonderful ideas and information. Listen, I wish we had more time. Unfortunately, we have to come to an end now. But I think that even though we were not able to cover absolutely everything, I think this was food for thought in terms of ideas as to what to change in our practices and our organizations. This is obviously, I would say, a lifelong effort in terms of better understanding some of these challenges and implementing all these changes. It's an important mission for all of us to provide optimal care to absolutely everyone, regardless of race and ethnicity and other factors. But clearly there are communities and populations that need our help even more at the present time. So I think this has been really a wonderful opportunity to share some of these ideas. I want to thank Ruben and Tiffany for being with us today. I'll ask you, because otherwise I would feel bad. You both have 20 seconds for a final remark, just as a final message to the audience. Ruben, 20 seconds, please.
Yes, I'm going to only emphasize one thing, that it's always the people and the policies that shape up our systems. So anytime you can make an impact on people, and for us, it may be just one patient whom we are sitting in front of today. So that's just a thought that I'm going to leave you with today. So thank you for being here, and thank you, Dr. Caballero, for inviting me.
Thank you, Ruben. Tiffany?
I also want to thank everyone for the opportunity to be here again, but I would emphasize to continue the work you're doing, and that everybody is impacted by social determinants of health. So we all play a role in addressing this in healthcare.
Absolutely. Absolutely. Well, thank you all for joining. Thanks for participating. I think it was sent in the chat. You will receive a survey through your email. So please provide us with your feedback. We're always looking into how to improve our activities. And again, I want to thank the American Diabetes Association, the American Heart Association for this wonderful opportunity to share some of these important concepts with all of you. Thank you for joining. We'll see you next time and continue with all the wonderful work that you all are doing. See you next time. Thank you very much.